Hi, welcome back. We're going to continue our discussion of pressure injury prevention. In the last video, we talked about general principles of pressure injury prevention. We talked about how to set up a program, and we talked about what a program should include. In this video, we're going to focus specifically on the role of support surfaces in pressure injury prevention. And let me just tell you right up front, we're going to stay focused on broad concepts, general principles. Support surfaces can be overwhelming, and you don't want to get lost in the weeds. When I go to a conference and I walk into the exhibit hall and I see all of these beds, it makes me want to run. So I've been in this a long time, and if they're still intimidating to me sometimes, I can certainly understand why it would be an intimidating topic to someone who's new to the field. But here's what we want you to focus on. We want you to focus on what it is that support surfaces do. We want you to know current terminology. We want you to know what you're looking for when you're selecting a support surface for an individual patient. If you understand those things, then you're going to be able to work with your vendors to determine, okay, what surfaces are available to you based on your buying and rental contracts. You want to learn about the specific support surfaces offered by your vendors so that you can then sound intelligent to your staff when you're helping them make decisions about which patient gets which product. And as you'll see, most of the time your decisions come down to maybe 4 major categories. Your standard support surface that should be on essentially every bed. Your higher level rental support surface that's going to give you additional features that we're going to talk about. Your pulmonary care surface and your bariatric surface. If you can be really clear on what features are provided by your standard mattress, by your primary rental surface, by your pulmonary care surface, and your bariatric surface, you're in good shape. You can always build on that, but that's where you start. Okay, so let's back up. Let's talk about what it is that support surfaces do. And you want to think about, well, which risk factors can be addressed and reduced and impacted by the best support surface for that patient. And of course, the primary risk factor is reduced mobility, reduced activity, the patient who tends to lie in one position until staff comes to turn that patient. There's 2 ways to reduce the negative impacts of immobility. One approach is to select a surface that's extremely conformable. Those surfaces work by allowing the patient to literally sink into the surface so that their weight and the pressure is evenly distributed across the entire contact area. So if I'm lying supine, my contact area involves my head, my trunk, my lower extremities, my heels. If I'm on a rigid surface, of course, all of my weight is suspended by my bony prominences, the occiput, the shoulders, the sacrococcygeal area, and the heels. But if I sink in, my weight's evenly distributed, you eliminate those peak pressures, and you help to maintain blood flow. So if you put a patient on a very conformable surface, you increase their time tolerance. You reduce the absolute pressure against their skin. If you reduce pressure, you increase the time that the patient can safely remain in that position. The other approach is to put the patient on an alternating pressure system. Alternating pressure systems constantly change the pressure points. We'll talk about that more in just a few minutes. So it's a different approach to protecting the skin. So with alternating pressure, yes, you have pretty high pressure against the skin when this air cell's inflated, but it's only going to be inflated 10 to 15 minutes, and then it's going to deflate when this air cell is inflated. So you're constantly changing pressure points and restoring blood flow. So the number one risk factor that support surfaces are designed to address is the adverse impact of immobility. And support surfaces address that in two different ways, either by providing a very conformable surface and reducing pressure against the skin, thereby buying more time, or by constantly changing the pressure points so that you're compressing but then reperfusing, compressing, reperfusing. What else can a support surface do for you? Most support surfaces now, most of the mattresses, if you pull back the sheet and you run your hand across the surface of the mattress, you're going to find that it's a fairly slippery surface. It might be Gore-Tex, it might be a comparable material. Those surfaces are designed to reduce shear and friction so that when the patient slides, at least there's no drag. At least when the patient slides, all layers are moving together. So many of your surfaces, in addition to addressing the impact of immobility, also reduce shear and friction. And some support surfaces also address moisture. The term that's being used a lot right now is microclimate control. When we talk about microclimate control, we're talking about a surface that reduces skin temperature and keeps the skin drier, typically by blowing air against the skin, but some of the newer surfaces work by pulling moisture away from the skin. So microclimate control means we're addressing the adverse effects of heat and moisture. So your very highest level surfaces will give you all three of these. They'll give you either a very conformable surface or one that constantly changes pressure points. They'll give you a surface with a low shear, low friction cover. They'll give you a surface that addresses microclimate, either by blowing air against the skin or wicking moisture away. But there are risk factors that are not addressed by a support surface. And we point this out because sometimes nurses feel like once they get the patient on a really good support surface, that they've essentially protected the patient. And of course, that's never true. A support surface plays an important role in protecting the patient against pressure injury, but it's never a standalone therapy. Support surfaces don't feed patients, so we still have to provide them with nutritional support. Support surfaces do not improve perfusion to the lower extremities, so if you have a patient with a heel ulcer, you still have to address all of the vascular issues. They still need a vascular consult. They also need their heels off the bed. Unfortunately, support surfaces do not address the adverse effects of aging, so they don't turn the clock back. Otherwise, we would all be sleeping on these all of the time. So you want your staff to think of support surfaces as being one element of a comprehensive pressure injury prevention program, but only one. Now let's go over some general principles that you always want to follow. You're going to select the surface for an individual patient based on a thorough assessment of that patient. You want to know, well, what are this patient's risk factors? Is this patient immobile? Well, then I want a surface that addresses mobility issues, that either gives me a conformable surface or constantly alternates pressure points. I want to know that that surface has a proven track record in protecting the skin and either evenly distributing the pressure or constantly changing pressure points. So I'm going to ask the company, show me your data. And can you give me the names of some other agencies that have used this surface so I can talk to them about what impact it had on their pressure injury rates. I also want to think about whether or not this patient needs microclimate control. So if I have a patient who has no moisture issues, the patient's not diaphoretic, the patient's not incontinent, then microclimate control is irrelevant to me. I don't need that for that patient. I need to just focus on a surface that evenly distributes pressure or constantly changes pressure points. But if I have an ICU patient who is both immobile and diaphoretic and incontinent, then I need a surface that addresses the effects of immobility by giving me either even pressure distribution or alternating pressure. But I also need a surface that addresses temperature and moisture. I need a surface that provides microclimate control. So I have to think about, what does this patient need? I have to think about the patient's weight. Does the patient need a bariatric surface? And is the patient high risk for falls, and do I need to think about getting a surface that goes very low to the floor? And finally, I need to rule out any major contraindications to specific surfaces. For example, the patient with an unstable cervical spine shouldn't be on an air surface until that spine has been stabilized. So we just have to think about those things. So I'm going to match the surface to the patient. What do they need? A conformable surface and microclimate control? Do they need a bariatric surface? Do they need a low bed? And are there any medical conditions that might be a contraindication, with one of the major ones being unstable cervical spine? Continuing on with general principles. How many nurses that you've worked with have felt like if they had the patient on a really good support surface, they didn't have to worry about heels? But all of the current evidence-based guidelines say that no matter what surface that patient's on, heel should be off the bed. You palpate your own heel. The calcaneus is a big bone. There's practically no soft tissue overlying the heel bone. So it's almost impossible to keep pressures against the heel low enough to maintain adequate blood flow. That's why all current evidence-based guidelines say get the heel off the bed no matter what surface they're on. What about repositioning? Sometimes staff believe that if they have the patient on a very high level surface, the patient doesn't need to be repositioned. That if the patient's on a continuous lateral rotation bed, they don't need to be repositioned. But again, what does the evidence say? The evidence says that all patients should be repositioned if they can tolerate it. Because repositioning does more than protect the skin. Repositioning is good for the lungs, it's good for the vascular tree, it's good for renal function. So you want it to be a rule of thumb in your agency. No matter what surface they're on, heels are off the bed, and everyone gets repositioned unless it's specifically contraindicated. When would repositioning be contraindicated? Well, an unstable spine. We don't turn people with an unstable spine until we've fixed that problem. What if I have an end-of-life patient and they've clearly said, I care more about comfort than I do about skin protection. I really am not worried about getting skin breakdown. I just don't want to hurt. Please leave me alone. I'll let you know when I'm ready to turn. Okay, we need to document that and we need to respect that. What about patients who are hemodynamically unstable? Now, for many years, this has been considered a contraindication to turning and repositioning. Patients who are hemodynamically unstable were considered to be very high risk for turning. And certainly all of us have encountered situations when we went to turn a patient who was critically ill, and when we turned that patient, they dropped their O2 sats, they dropped their blood pressure, they became tachy, whatever. That led to the perception and to the widely accepted principle that hemodynamically unstable patients should not be repositioned. However, that has recently been challenged. the Virginia Commonwealth University Medical College of Virginia recently held a major consensus conference where they pulled many people together, critical care specialists, vascular specialists, pulmonary specialists, skin specialists, to look at the whole issue regarding repositioning of hemodynamically unstable patients. They discussed not only the potentially negative effects of turning, but the potential negative effects of not turning. Potential negative effects of not turning are increasing instability, because when we turn, we have a number of mechanisms that kick into place, vascular mechanisms that shift blood flow to maintain blood pressure in different positions. But if we never turn that patient, we never activate any of those vascular mechanisms, they become less and less competent. So the longer that patient goes without being repositioned, the more hemodynamically unstable they become. However, two major things that came out of this consensus conference, actually three. The first one was very critically ill patients with some degree of hemodynamic instability do need to be repositioned from a vascular perspective as well as a skin care perspective. Number two, how do we define hemodynamically unstable? And the current recommendation is, if the patient returns to baseline in terms of O2 sats, in terms of blood pressure, in terms of pulse rate, if the patient returns to baseline within 10 minutes of a turn, they tolerated that turn. So the recommendation is, don't react to that initial change. Don't react to that drop in O2 sat. Don't react to that drop in blood pressure, that increase in pulse rate. Monitor the patient over the next 10 minutes, and if they come back to baseline, they tolerated the turn, and turning should be continued. One of the most important take-home messages, at least for me, was that maybe we need to modify our approach to turning. So here's the way I turned patients for many, many years, and still I turn a lot of patients this way. So I and maybe one other nurse, I'm on this side, somebody on the other side. 1, 2, 3, turn. How many of you have done that? That's fine for the average patient, but if I have a patient with some degree of hemodynamic instability, that approach to turning can overwhelm their compensatory mechanisms. So the recommendation is a very slow turn and a limited turn. So when I'm introducing turning to this critically ill patient, we should turn very slowly and maybe only 10 degrees and wedge them. Over the next 24, 48 hours, hopefully we can advance them to a 30-degree tilt. So revisit concepts related to hemodynamic instability. Okay, so we've talked about general concepts. You're going to try to match the surface to the patient. You're going to consider whether or not you're primarily concerned with pressure redistribution, or whether you also have to address microclimate control. You're going to make sure that everybody gets turned unless there's a strict medical contraindication. You're going to teach everybody new guidelines for turning critically ill, potentially hemodynamically unstable patients. You're going to emphasize to everyone heels off the bed. And of course, for everyone, we're constantly monitoring skin status. If the patient starts to deteriorate on a lower level surface, we should bump them up to a higher level surface across the board. Now what I want to talk about is I want to introduce some new terms and definitions. Terms and definitions related to support surfaces have changed a lot over the years. These are the terms you're likely to see on the certification exam. We'll probably talk about this briefly when you come on site for Bridge Week. So the first term I want you to know is constant low pressure, CLP. That refers to a surface that provides very even distribution of pressure across the entire contact area. So this may be a foam mattress, it may be a gel mattress or cushion, it may be an air mattress or cushion. It works through that even distribution and by reducing the intensity of the pressure against the skin surface. It's the opposite of alternating pressure. So constant low pressure means you put me on an air surface, a gel surface, a foam surface that's designed to be conformable, that allows me to sink in so that I get contact between my body and the underlying surface all across the contact area. Now there's two related concepts. I want you to focus primarily on what does constant low pressure mean. It means that you have a conformable surface that evenly distributes pressure. Then they'll talk about two related concepts, immersion and envelopment. Immersion just means, well, how soft is the surface and how much can you sink into the surface? So if you have a very thin foam, it's going to allow you to sink way into the surface. It may allow you to sink all the way to the underlying mattress. You don't want that. You want the patient to sink into the mattress, but you do not want them to sink to the bottom. So immersion, how conformable is the top layer? Can I sink into the mattress? Envelopment means how conformable is the surface? Does it evenly conform to my body? So if you have a surface that's extremely conformable, like gel or air, when I sink into the surface, it's literally going to wrap around me. And it's going to assume the same shape as my body. And that's going to give me the best pressure redistribution. So I should sink into, and I should have a surface that literally conforms to my body. So how many of you have put your hand into an air surface, put your hand into a gel surface, put your hand into a high density foam like Tempur-Pedic? And you see, when you lift your hand, you can literally see the imprint of your hand on that gel surface, on that foam surface, and initially on the air surface. That's what you want to see happening. You literally want the device to assume the shape of the patient's body. Alternating pressure, we've already talked about it a little bit, is the opposite approach. So with constant low pressure, you're just trying to evenly distribute pressure. You're trying to eliminate peak pressure that could cause vessel compression. With alternating pressure, that's not what you're doing at all. Alternating pressure is a mattress with longitudinally oriented air chambers. Usually, these are horizontally, but most of them are longitudinal. And here's how it works. At any given point in time, about half of the air cells are inflated. So maybe air cells 1, 3, 5, 7, 9, and 11 are inflated. 2, 4, 6, 8, 10, 12 are deflated. 10 minutes later, 15 minutes later, when the machine cycles, air cells 1, 3, 5, 7, 9, 11 go down, 2, 4, 6, 8, 10, 12 comes up. So you see what you're doing? Constantly changing pressure points. So it doesn't matter that I have high pressures against 1, 3, 5, 7, 9, and 11 because that high pressure will only be exerted for 10 to 15 minutes and then that pressure will go away. Constantly changing the pressure points. Now you'd like to know, well, which is better? Is constant low pressure better or is alternating pressure better? And recently, WOCN, Wound Ostomy Continence Nurses Society, actually brought a group together to do an in-depth lit search on support surfaces to try to answer questions like this. And you want to know what the answer is? The answer is, we're not sure. because practically no studies had been done. One or two very limited studies suggested that, this was not conclusive, suggested that if your patient has very, very limited mobility or no mobility, they might do better on alternating pressure. But nothing conclusive, nothing that you could hang your hat on. So at this point in time, you should consider constant low pressure, alternating pressure, two different approaches to achieving the same goal, maintaining tissue viability. One reduces absolute pressure, extends the tissue tolerance. The other constantly changes pressure points to maintain tissue viability. Now, a couple of other terms, you won't see these as much, I don't think, but just so that you recognize them, reactive and active. Reactive means that the support surface changes in response to the patient. So if I'm lying supine on an air support surface or a foam surface or a gel surface, and you come and you turn me to my right, you tilt me to my right, the surface is going to shift underneath me. That foam is going to adjust, the air is going to adjust, the gel is going to adjust in response to the weight of my body. So reactive is just that. The device reacts to changes in patient position. So your constant low pressure surfaces are reactive. That foam, that gel, that air. As the patient moves, the foam shifts, the gel shifts, the air shifts, all with the goal of maintaining very low pressures against the contact area. An active surface changes. There's a constant change in pressure points. If you watch an alternating pressure mattress, it doesn't matter whether the patient's on it or not. It's not reacting to the patient. It's changing based on a preset cycle. So if I put an alternating pressure mattress on the bed and turn it on, it's going to start cycling. It doesn't matter that the patient's not there yet. So an active surface is a power surface with air chambers. They're alternately inflated and deflated, irregardless of whether or not the patient's on the surface. Two other terms, low air loss and air fluidized. Now, if you're like many of us, you have referred to some air support surfaces as low air loss surfaces and others as air fluidized. But recently, a group that was convened to look at support surface, look at terminology, try to establish some standards, said, listen, you need to look at low air loss as a feature of an air support surface. Low air loss means that you have micro perforations in the surface of the mattress. The mattress is hooked to a pump that causes constant low volume airflow against the skin. So when you say low air loss, it means the air is blowing against the skin at a slow rate. And it's designed to help keep the skin cool and dry. It's a microclimate control feature. So you might have what you formerly called a low air loss bed. And by new terminology, it would be an air surface that provides constant low pressure and low air loss. So low air loss is a feature. It doesn't define the surface. It's only one feature of the surface. You might have an alternating pressure mattress that also provides low air loss. So constant low pressure, alternating pressure, low air loss, those are all features. So you just want to realize that new terminology no longer labels a bed by that low air loss feature. It could be paired with constant low pressure. It could be paired with alternating pressure. And if that's confusing, feel free to call us and we'll try to walk you through it. Air fluidized, I will probably always think of these as beds because it is a unique technology. But they would point out that if you have a patient on an air fluidized bed, you have them on a constant low pressure surface that provides high air loss through this air fluidized feature. So I want you to be aware of new terms because I don't want them to trip you up on the exam. But I also want you to plug them in ways that work for you. Constant low pressure versus alternating pressure, yes, very distinct features. You should definitely understand those. You should understand what we mean by a low air loss feature. What makes a surface low air loss? And what do we mean when we say that you're putting the patient on an air fluidized surface? Well, you know, it means that you have a tank. It's full of glass beads. The glass beads are coated with silicone, so they're very slippery. And you have a sheet covering that tank. Now, when you turn on the power, it blows air through the glass beads and literally creates this fluid surface. The patient floats on the surface. When you put a patient on an air fluidized surface, what do you get? Very high level, constant low pressure, because literally the surface conforms to the patient. Very, very high level, constant low pressure, and high level airflow. Now, there are some disadvantages to these air fluidized beds. They generate a lot of heat, they're very heavy, they're very expensive. Because the patient's down in the bed, they can be disorienting, and it's difficult to maintain head of bed elevation with your true air fluidized beds. That's why there's also some hybrids available where the trunk is protected through this air fluidized therapy, but you have the top half of the bed can be elevated to provide pulmonary care. At this point, just be clear on your terms. A couple of other things. Continuous lateral rotation therapy, CLRT. What does that mean? That's a surface designed for pulmonary care. I want you to pay attention to this because the terminology, continuous lateral rotation therapy, suggests that my patient's being turned by the bed and that I don't need to turn them. But in reality, continuous lateral rotation therapy was designed specifically to counteract the negative effects of immobility on pulmonary function. So the big concern is with lung fields. And what you see here is, yes, the bed shifts, but only the upper body is being turned. So with most CLRT devices, the focus is on upper body, rotating the lung fields. And what happens at the level of the trunk? Nothing. The trunk remains stationary. The upper body moves. So what do you need to teach your staff? With most continuous lateral rotation therapy beds, the patient still has to be turned because you have to protect the trunk. The heels still need to be offloaded because you need to protect the heels. So unless you have a device that clearly turns the entire patient, and you have verified that, everybody gets turned. What about bariatric support surfaces? Well, most of us are dealing with a lot more bariatric patients. So we have more patients in our caseload who are heavier than 350 pounds, maybe heavier than 500 pounds. We also may have patients who technically are between 250 300. They're kind of on the borderline in terms of whether or not they need a bariatric surface. But when we look at their build, we find that they have very wide girth. Their weight is concentrated in the trunk area. And it's very difficult for them to turn because they don't have enough room. So you need a bariatric bed for any patient who's more than 300 to 350 pounds, but also for patients who have very wide girth that interferes with repositioning. If you have bariatric patients, in addition to putting them on a bariatric surface, you have to think about, well, how are we going to safely reposition this patient? What repositioning systems are available to us? Do we have ceiling lifts? Do we have repositioning systems that go on the bed and involve air bladders that make it much easier to move the patient around? What else should I be thinking about in addition to getting this patient on a bariatric surface? So we've talked about therapeutic features, we've talked about new terminology. When you're selecting a surface, you're much more concerned about the therapeutic effects than anything else. And so we're primarily going to focus our discussion, our classification of support surface to therapeutic effects. So when you hear people talking constant low pressure, alternating pressure, constant low pressure with low air loss, all of those terms, those approaches to classification are focused on therapeutic effects. That's where you want to focus your attention. But you can also look at classifying a device based on its relationship to the mattress and the bed. For example, if it's designed to go on top of the mattress, it's an overlay. If it's designed to replace the mattress, it's a mattress replacement. And we also have specialty beds. So is it an overlay? Is it a mattress? Is it a bed? And then finally, we frequently classify based on the support medium. So is this a foam mattress? Is this an air mattress? Is it an air foam combination? So we're going to talk about each of those. What do we say? Therapeutic effects, by far the most critical. That's where you want to focus your attention. It's all about therapeutic effects. Pressure redistribution, the primary therapeutic effect of all support surfaces. So we've talked about conformable surfaces that provide very even pressure distribution and eliminate peak pressures. We've talked about the fact that alternating pressure surfaces work differently by constantly changing pressure points. We've talked a little bit about the fact that constant low pressure surfaces work by reducing pressure intensity and thereby improving time tolerance, whereas alternating pressure reduces the duration of pressure. Okay, so first this air cell's elevated or inflated and you have high pressures against this area of the skin, but then it comes down and this one goes up. So even though you have higher pressures, you have shorter duration. We haven't talked a lot about bullet point 2, but it's an important bullet point. At this point, we have very little evidence, no definitive evidence, that one surface is better than another. Now, a lot of us, as clinicians, believe that an air support surface provides higher level protection than a foam support surface. And some of us, or many of us, if we have a patient on a foam pressure redistribution surface, constant low pressure foam, if that patient develops any deterioration on the foam, we will move them to a constant low pressure air surface because we believe that air, being a gas, shifts more rapidly in response to the patient's weight and gives higher level pressure redistribution. That's a clinician belief, a clinician perspective. It underlies a lot of clinician decisions, but when you go to the evidence, those studies have not been done, And at this point, we have very little evidence that one surface is better than another. A handful of studies suggest that if you have a patient with stage 3-4 pressure injuries, and you have them on a pressure redistribution foam mattress or a pressure redistribution air mattress, you're doing everything correctly to get the wounds to heal, you're providing nutritional support, glycemic control, all of those things, and the wounds are not improving. There's very few studies that suggest that if you put that patient on an air fluidized surface, those wounds may improve, those wounds may heal. Is that definitive data? No. Just a handful of studies. A handful of studies suggest that if you have a totally immobile patient, alternating pressure might give you better outcomes than constant low pressure. None of those are definitive. So if you were asked on the exam, which of the following provides the highest level protection or is the best choice for a patient who is totally immobile, and alternating pressure was one of the options, you would pick that based on that little bit of data. But across the board, no definitive guidance in terms of what's the best. In our minds and in practice, air fluidized therapy is considered to be kind of the top of the pyramid. If you have people who have failed other therapies, you might think about air fluidized. But again, limited data. So what's the take home? Everybody should be on a pressure redistribution surface. You can go either constant low pressure or alternating pressure. If you choose constant low pressure, very limited evidence that if you have a patient who has failed other therapies, they might respond better to air fluidized. Very limited evidence that if you have a patient who's totally immobile, they might do better with alternating pressure. Other than that, studies indicate as long as you provide pressure redistribution, as long as you provide microclimate control when indicated, it doesn't seem to matter which pressure redistribution surface you use or which approach to microclimate control you use. Now, as we get more data, our recommendations may change. So we talked a lot about the importance of addressing the effects of immobility either through constant low pressure or alternating pressure. We've talked a good bit about microclimate control. What about shear and friction control? Well, most of the surfaces out there now have that slippery top cover that has stretch and has give. And those slippery, stretchy covers help reduce shear, help reduce friction, so that when the patient slides down, you're eliminating that drag. This is important. If I knew how to make this happen, sorry, I would probably be rich because I'd be on some big speaking circuit across the country. Almost every hospital in this country and across the world really has pretty good quality constant low pressure mattresses on their beds. Pretty much every ICU patient is on a high level air support surface, either constant low pressure or alternating pressure, with low shear, low friction covers, and microclimate control. Still, we're seeing a lot of sacrococcygeal ulcers. Why is that? This is one reason. If I get a very high level surface and I put you on that surface, but I put multiple layers between you and the surface, so yes, I have this great surface, and then I have a sheet So I've got my bottom sheet, I have my draw sheet that's at least 2 layers, might be 4 layers depending on how it's folded, and then I have underpads. How is that going to affect the level of pressure distribution and the degree of microclimate control? Well, it's going to affect it a lot. So you have to think every layer that you put onto that surface, every layer between the patient and the surface compromises the therapeutic effects of the surface. That means you have to do concerted education, not only to the nurses, but who makes the beds, who changes the patients, who determines how many underpads go under the patient, who determines how the draw sheet's folded. And it's usually your nurse techs. And until you educate them, they don't know that multiple layers are a negative thing. They're just trying to keep the bed dry. They know the patient's incontinent because we're running around taking out catheters. So they're layering up protective pads, thickening up the draw sheet. We've got to educate everyone. It matters, especially if we're trying to get microclimate control, but also it affects the ability of the surface to adjust, adapt to changes in the patient's position, weight bearing. So multiple layers compromise the protection against immobility, compromises the ability to keep the skin cool and dry. Got to pay attention to that. Okay, so now we're going to try to put it all together. You're trying to make the best decision for John Smith. So what do you have to think about? You have to think about, well, is this a bariatric patient? Should I put them on a bariatric bed? I should think about that right up front. Is this patient major fall risk and they need a low bed? I should think about that right up front. I need to pay a lot of attention to how this patient scored on the mobility subscale of the Brady scale. If a patient scores 1 or 2, then I need a support surface that either provides high level envelopment and immersion, constant low pressure, or a surface that provides alternating pressure. So that's my first big concern once I determine whether or not they need a bariatric bed, a low bed, or a standard bed. Then I'm focused on, okay, should I be putting them on a foam, constant low pressure, air, constant low pressure, alternating pressure? What do I have available? I've got to think. What did they score on the moisture subscale score? Is this patient diaphoretic? Then I'm not going to put them on a foam, constant low pressure, because I have to put them on a surface that provides airflow, that either blows air against the skin or wicks moisture away from the skin. So if I have a patient who's immobile and diaphoretic, I have to select a surface that addresses pressure and also addresses moisture. And then I want to think about, okay, does this patient have breakdown at baseline? How many surfaces are involved? Because in general, if I have a patient who's either extremely high risk or who already has breakdown on a number of surfaces, I'm going to go with a higher level surface. I'm going to go with air over foam, air over gel. WOCN's group that did the lit review also came up with an algorithm, a general algorithm for support surface selection. In their lit review, the 2 factors that played the most important roles in decision making about the best surface were mobility issues and moisture issues. So this is how the algorithm breaks down. If you have a patient who scores 1 or 2 on the mobility subscale and 1 or 2 on the moisture subscale, they should get either a constant low pressure surface or an alternating pressure surface that also has a low air loss feature or a microclimate control feature. okay? Because I've got to address both pressure and moisture. So look at those two subscale scores. In mobility, exposure to moisture. If I'm dealing with both of those, then I have to have either constant low pressure or alternating pressure with airflow or with wicking. What if I have a patient who's very immobile, but they're not diaphoretic, and maybe they're incontinent of stool, but only once a day, and they have a catheter in? Okay, well then I don't really have to worry so much about moisture control. I can focus pretty much on pressure redistribution. So I can either do constant low pressure or alternating pressure. I don't have to have low air loss. So in this case, I could do an air surface that gave me constant low pressure. I could do a foam surface that gave me constant low pressure, because low air loss is not an issue. What if I have a patient who's diaphoretic, maybe incontinent, but they're moving around in bed pretty well? So mobility is not such an issue, but moisture is a big issue. So now I'm going to select a surface either with low air loss or with wicking functions. My big focus would be microclimate control. If I have a patient who has existing breakdown, then I need a surface that provides very high level, constant low pressure or alternating pressure. So typically I would be looking at an air support surface. All of your alternating pressure surfaces are air-based, and many of our constant low pressure surfaces are air-based. So most of the time when you have a patient who comes in with existing breakdown, typically we do not leave them on a foam-based mattress. Typically we move them up to an air-based surface. Now this is old terminology, so I don't want you to lock into the terminology, but I think the concept is still very helpful. And that is the concept of a high-level device versus a mid-level device, and who gets which one. So when you think of a high-level device, you want to think of an air support surface that provides you low shear, low friction, and typically also provides you with low air loss. Who needs that very high-level, constant low pressure and shear friction control and possibly low air loss? Your patient who cannot be turned needs the highest level system you can provide. So it would either be air-based constant low pressure with low shear, low friction, and low volume airflow, or it could be alternating pressure air surface with a low shear, low friction cover, and low volume airflow. Bottom line, you would put them on an air surface, you would make sure they had shear and friction control, and if indicated, you would put them on a surface that also provided microclimate control. So patients with breakdown, patients who cannot be turned, patients who are in severe pain that significantly limits their mobility and their ability to tolerate turning. Mid-level. Mid-level is where most of our patients can be managed. So if you're on a medical surgical unit, your patients are going to be on mid-level mattresses. This would be a pressure redistribution mattress. It might be foam-based. It might be a combination of foam and gel. It might be a combination of foam and air. If you're in home care, you might be talking about an air overlay or a foam overlay. Who can be managed with that type of device? Patients who have no breakdown at baseline, or they have breakdown on one surface that can be offloaded, and they're at moderate risk. Now, how does this play out in most agencies? So most of you, if you're acute care based, you have a pressure redistribution surface on all of your beds. So your mattresses are pressure redistribution. Most of the time they're foam-based. Most of them have a low shear, low friction cover. Most of them do not have airflow. So most of your patients on your medical surgical units would meet the criteria for management with a mid-level device, constant low pressure foam, constant low pressure foam gel. Your patient's moderate risk. They have no breakdown or one area breakdown, you can turn them. Yes, you can manage the patient on that surface. Now, what if you have a patient who is on that surface and they develop stage 1 pressure injuries? Do you need to think about moving them up? Yes. What if you have a patient on a mid-level surface? So let's say it's foam-based, pressure redistribution, low shear, low friction, no airflow. Your patient becomes diaphoretic and their Braden score goes from 16 to 11. Would you think about moving them up to a surface with low volume airflow, with microclimate control? Yes. Do you think in general of mid-level surfaces as being your foam mattresses with no airflow? You think of your high-level surfaces as being your air surfaces, your air mattresses, either constant low pressure or alternating pressure. Your air surfaces almost always have low volume airflow or wicking capacity. So most of your air mattresses will give you high-level pressure redistribution and shear friction control and microclimate control. That's what your ICU patients need. That's what your critically ill patient needs. That's what your patient needs who develops deterioration on the lower level surface. So try to think within your agency, what do you have on your med-surg beds throughout the agency? Probably pressure redistribution, probably foam-based, and for many patients that's enough. Who needs to be bumped up to a rental surface, to that higher level surface, to air support, either constant low pressure air or alternating air? Who needs a surface with microclimate control? Your diaphoretic patient, your critically ill patient, your patient whose skin is deteriorating. Looking at devices in relationship to the bed, very simple. We started out with a lot of overlays. Now the trend is that if you're in an inpatient facility, you are moving away from overlays. You may have already moved totally away from overlays because they add height, which becomes a safety issue. There's increased risk of falls, increased risk of entrapment. And also it means it's something you have to constantly do. You have to go get the overlay, put it on the bed. So most inpatient agencies have moved away from overlays. But these can be a good option for home care. So you still want to be aware that they're available and that they can be very helpful in providing pressure injury protection. Mattress replacements. So original hospital mattresses had no ability to evenly redistribute pressure. All of the new hospital mattresses are pressure redistribution mattresses. So what you should have on your beds, if you're in an acute care setting, are mattresses that incorporate a pressure redistribution feature. Typically, they are a combination of foam or foam and gel, occasionally foam and air. You can rent or purchase pressure redistribution mattresses. Now, the mattresses that go on beds throughout the hospital are obviously purchased. You can also rent mattresses if you want a mattress with unique features. Purchase mattresses, that should be your standard of care throughout your agency. You can see what we mean by a purchase pressure redistribution mattress is going to combine the features of the standard mattress, which means you can do terminal cleaning, you can use it over the course of several years. They will provide pressure redistribution. They do not typically provide moisture management. Should be the standard of care now. All of our patients are much higher risk. When you put a patient on a bed in your agency, you want to make sure that that patient is getting baseline pressure injury protection. Very important for you to look at this last bullet point. Pressure redistribution mattresses come with a warranty period. So you have to know what that is. When were those devices placed in your hospital? And how long are they covered by the warranty? So if you are the new WC nurse, it's important for you to know that the mattresses that are on your beds have a 4-year warranty, and they were placed in 2015. That buys you a little bit of time. You have till 2019 and you should be replacing them. So you want to know that. You need to talk to purchasing or materials management. Rental mattresses. These are usually air support surfaces. They're typically pump driven. They, in most of our minds, there are high level surfaces. They either provide high level, constant low pressure, or they provide alternating pressure. They provide low volume airflow or a wicking feature that helps provide microclimate control. They're delivered and set up by the company. Most of us use rental beds. You can also rent the mattress, but I imagine that you're going to see many more beds coming down the hall and not as many mattresses. So the nice thing about rental beds is you can get additional therapeutic features because the mattress is therapeutic, and you can also get features built into the bed frame like in-bed scales, things like that. So for most of you, you want to focus your attention on 2 things. What are you getting from your standard hospital mattress? What are you looking for? You want good quality pressure redistribution, and you want to make sure that the cover has stretch and shear friction reduction features. That's what you want from your standard mattress, and you need to know the warranty period and when they were placed. The second thing you're going to pay a lot of attention to is what's available to you on a rental basis. It could be a rental mattress, usually it's a rental bed. What should you be getting from your rental bed? That your high-level surface is going to give you either high-level constant low pressure or alternating pressure. It's going to give you low shear, low friction. It's going to give you microclimate control, and it may give you additional features. The last way to look at devices is what are they made of? So we've looked at therapeutic effects. We've looked at relationship to the existing hospital bed and mattress. And then the last thing to consider is, okay, if I pull back the cover, what's on the inside? Foam is widely used. It's widely used for overlays, for chair cushions, and for your standard replacement mattresses. There's so much variability in the quality of foam, so you really have to pay attention to what you're getting. Therapeutic foams have specific terms, so look for these words. High specification foam. So like your Tempur-Pedic mattresses, those are high specification foams. High specification foams are designed to be very conformable and to have memory. So you've heard the term memory foam. So when I sink into the mattress, it conforms to my body contours. But when I turn, it changes. When I turn back the other way, it changes again. It has memory. So therapeutic foams, they do provide effective pressure redistribution. They don't provide moisture management. What about gels? We don't see a lot of gels. Gels are heavier, so if you had a gel mattress, it becomes very heavy and difficult to manage. So you're primarily going to see gels and overlays or wheelchair cushions. It's a heavy liquid. It does provide effective pressure redistribution. It can reduce shear force, does not provide moisture management, but some of your wheelchair cushions will be gel-based. And so you think, well, what is gel? It's a heavy liquid. But I want you to focus primarily on foam and air because those are the devices you'll use every day. You can get air devices as overlays, as chair cushions, as mattresses, or as rental beds. And of course, as a rental bed, we're focused on the mattress itself. What do you get from air? You either get very high level conformability, that constant low pressure, or you can get alternating pressure. You can get air surfaces with a pump or without a pump. If you have a constant low pressure surface and it's pump driven, the pump maintains constant inflation. But if you lose power, you lose inflation. If you have a pump-driven system and you have little perforations in the mattress itself, you can get low volume airflow. All of your low air loss beds and mattresses are pump-driven, right? Because they're blowing air against the skin. What about your air support devices that don't have a pump? So this has a pump, this does not, this does not. If there's no pump, then you have to inflate the device based on manufacturer's guidelines. Really important to follow guidelines. If you don't have enough air in the device, if it's underinflated, you don't get adequate pressure redistribution, the patient's going to tend to bottom out, sink through the mattress, through the cushion to the underlying chair or bed frame. If it's overinflated, then the patient can't sink in. You lose conformability. You lose that whole immersion envelopment feature. The patient's perched up on top and they're getting high peak pressures. Absolutely critical to achieve the correct level of inflation. So you have to go by manufacturer's guidelines. Okay, so if it's not pump driven, follow manufacturer's guidelines to get the correct level of inflation. Now, specific considerations related to air support surfaces, and you'll spend a lot of time working with air support surfaces. Most of your ICU beds will be air support mattresses. Most of your rental surfaces will be air support. So what do we say about low air loss? Low air loss provides microclimate control by blowing air against the skin. Newer approaches to microclimate control sometimes involve wicking moisture away from the skin. But if you have a patient who is diaphoretic, where they score 1 or 2 on the moisture subscale, make sure you're addressing microclimate control, typically through low air loss, but newer systems being developed. Devices that are labeled low air loss mattresses or low air loss beds, because manufacturers still use that terminology sometimes. What does that mean? It means that you have an air support surface, typically constant low pressure, sometimes alternating pressure. It means there's microperforations in the surface, air's being blown through to provide microclimate control. Most of these mattresses, in addition to providing microclimate control, high level pressure redistribution, also provide friction and shear reduction because the characteristics of the mattress cover. It's slick and it has stretch. What about air fluidized beds? Those high air loss beds. So remember, Air fluidized is considered a feature. Low air loss considered a feature. But you'll still see beds and mattresses labeled low air loss. You want to know what that means. You'll still hear surfaces labeled air fluidized. You want to know what that means. What do you get from this kind of surface? Very, very high level pressure redistribution, shear reduction, moisture control. But unless you use a hybrid, it's very hard to maintain head of bed elevation. You're using a wedge, and it's hard to keep the wedge in position. Dehydration can be a major issue because of the high volume airflow, so you really have to pay attention. Also, dehydration of the wound surface. So if I'm doing, I hope I'm not, but if I'm doing damp to damp gauze dressings and the patient's on this kind of surface, my gauze is drying out very quickly. My wound surface is drying out very quickly. So things to think about. When would this type of device be used? At this point in time, it's pretty much limited to patients who have undergone flap surgery, and they're typically on this type of device or a very high-level air surface alternative. Might also be used for patients who have failed to heal on other surfaces. Remember that handful of studies that shows that patients who fail to heal on other surfaces despite appropriate management might heal on this. Dolphin is a new technology. This isn't Dolphin. I don't have Dolphin on there. This is the hybrid of this. Let me tell you about Dolphin technology device. So sometimes you'll hear surfaces referred to as a dolphin bed. And it's based on technology that was developed to transport dolphins. When they had to take them from this aquarium to that aquarium or this area to that area. Dolphins are big. And so they came up with a surface that is connected to a computer, and the computer is constantly monitoring interface pressures between the dolphin and the underlying surface and making adjustments to maintain very low interface pressures across the entire contact area. And that's exactly what Dolphin technology does. So Dolphin technology is now considered an appropriate alternative for a patient who needs the highest level therapeutic surface. So maybe a patient who formerly would have been placed on an air fluidized surface, but we want the ability to elevate the head of the bed. We might put them on a Dolphin surface instead, because Dolphin surface gives you very, very high level pressure redistribution, does give you low shear, low friction, does give you microclimate control. Hang in there, we're almost done. Okay, chair cushions. Anybody who's at risk and gets up in the chair needs a chair cushion. What about donuts? I still have people asking me about donuts, and this is what you tell them. Donuts are for coffee, not pressure redistribution, because donuts, even though they look like they offload the area of concern, they're actually compressing the tissue all around the at-risk area, compromising blood flow in and venous drainage. No donuts, okay? If you have a patient who is going to be using a chair cushion short term, it's just when they get up in the bedside chair, you can use foam, you can use air, you can use gel. But if you have a patient who's wheelchair bound, that wheelchair cushion is critically important because they're going to spend more time up than down. This is where we really need to refer the patient to a seating clinic if one is available. That's S-E-A-T-I-N-G if you don't understand my accent. Seating clinic. Physical therapy needs to have input because they need to match the cushion to the wheelchair. They need to think about distance between the chair and the heel rest. So you want to avoid hyperextension, okay, or excessive flexion. They need to be seated in the correct position. The cushion should be contributing to appropriate seated position. And it needs to provide even pressure distribution and low friction and shear and possibly microclimate control. So get PT input. You can get chair cushions, all of these, foam, gel, air. Foam is comfortable. It does give you really good seating stability, but what if you have a patient who's incontinent? What if you have a patient who's very diaphoretic? And it can be hard to transfer off foam if you have a patient who's chair-bound, bed-bound. Gel is a great choice for heavier patients because it supports weight more effectively. Easy to clean if the patient's incontinent, does not interfere with transfers. If the patient's in an environment where the temperature changes a lot, you can end up with lumps of gel. Like if sometimes the gel gets cold, they can end up having to knead the gel to evenly distribute it. So just one thing to think about. Air gives you lots of options. It's easy to clean. Transfers are not a problem, so we use a lot of air cushions. What's your role? You're probably thinking, I hope no role at all. This is a lot of stuff. Remember, get clear on the basics. What do you have available on your beds across your agency to provide base level support? You should have good quality pressure redistribution mattresses that are still in warranty. Typically, they will have a stretchy, low shear, low friction cover. They will not provide moisture control. You should have a rental contract that gives you access to high-level air support surfaces. It could be constant low pressure. It could be alternating pressure. If it's air support and it's pump driven, you should be able to get a device that also gives you microclimate control that blows against the skin or wicks away. So you need good quality mid-level device on all your beds and access to a high-level rental surface. You also need access to bariatric products. You need access to pulmonary care products. You do play an important role. A lot of WOC nurses refer to themselves as the bed Nazis or the bed police because they have decision-making authority. They're kind of the gatekeeper. For many people, it's the least favorite aspect of their job, but a very important one because your goal is make sure patients get what they need, avoid overuse of high-level surfaces. A critical role you play is assisting with product selection, with vendor selection. So you should definitely be on the committee that's making decisions about your hospital mattresses, about the vendor you'll use for rental surfaces. So remember, you should have input into what mattresses go on beds throughout the agency. You should have input into what's available at the high end of the spectrum. What can you get on a rental basis? You should make sure you have access to bariatric surfaces. You should make sure you have chair cushions readily available. You should have access to continuous lateral rotation therapy devices for your patients with pulmonary care issues. And when you're making decisions, you might have two companies and it's like, well, this one has a really good quality base mattress and this one does too. And looking at the devices available on a rental basis, this one's got high-level air support, so does this one. This one's got bariatric options, so does this one. This one has chair cushions, so does this one. This one has continuous lateral rotation therapy, so does this one. How do I pick? Well, ask them about their level of support. If you order a rental surface, how quickly will it be delivered? What if you have a problem? Who do you call? Is there coverage on weekends? Is there coverage on holidays? Does the vendor assist with education? What support do you get from the vendor? Are they willing to provide you references, other agencies that use their products, and what do those people say? So sometimes it's vendor support that makes the difference, because product line A and product line B are pretty much interchangeable, cost very comparable, so you think about how much support do we get. You want to develop a simple decision tree. You want to keep it as simple as possible for staff so that they know who gets managed on the standard surface that's on every bed. They should know who gets put on a bariatric surface, who gets put on continuous lateral rotation, who gets put on that high-level air support surface with airflow. And guess what? We are now through beds. Congratulations. We know it's a complex topic. We will talk about this a little bit when you're on site for Bridge Week. In the meantime, if you have questions, do call us. It's a critical aspect of pressure injury prevention. You want to get it right. Thank you.